Welcome back, everyone. We're going to continue the OBGYN series with discussing the Gravid Patient. Once an egg has been fertilized and implanted, major changes occur. Cells multiplying on the outside of the egg surface form layers that will ultimately generate the fetal membrane, the placenta, and the embryo. Fertilization, as a reminder, occurs in the fallopian tubes, and then early stages of division, we call that a zygote, and ultimately an embryo. And when we get to the stage known as the blastocyst stage, this is the largest accumulation of cells that are yet undifferentiated. Once cells become differentiated, we refer to the fertilized egg as an embryo. So as the blastocyst migrates to the endometrial wall and becomes implanted about a week after conception, that implantation triggers the development of placental tissue, and the corpus luteum produces hormones to support pregnancy until the placenta fully develops. About 2 weeks after conception, the blastocyst evolves into an embryonic disc. The embryo begins to draw on maternal circulation at this point, and at about 3 weeks after conception, the blastocyst officially becomes an embryo. Body system begins to form, the heart begins to beat, blood begins to circulate. In the 4th week of pregnancy, the placenta will develop, and this serves as an early liver that produces antibodies, functions as the fetus's lungs, transports nutrients, excretes waste, and transfers heat from the mother to the fetus. It also forms a barrier against harmful substances, and we often refer to this as the blood placenta barrier or the blood baby barrier. The umbilical cord connects the fetus to the placenta. The umbilical vein then carries blood to the fetus. Umbilical arteries carry blood to the placenta. The amniotic sac encloses the fetus in amniotic fluid, and the 4th through the 8th week of embryonic development are critical. Major organs and other body systems are most susceptible to damage as they form during this period. The gestational period is the time it takes the fetus to develop in utero. Normally, this is about 38 weeks, or commonly referred to as 9 months, and it's calculated from the first day of the pregnant woman's last menstrual period. And you can see some images here of fetal development and size over that period of time. There are significant changes that occur to the maternal patient during pregnancy. This can alter the normal response to trauma, exacerbate and or create additional medical problems, complications, and conditions. As we mentioned in a previous lecture, pregnancy in and of itself is not a disease process. The body is well evolved to adapt to pregnancy, and for the entire history of human existence, the species has continued through this process. Some of the changes that occur internally and externally. Before the pregnancy, the uterus weighs about 70 grams and has a fluid capacity of about 10 milliliters. At the end of the pregnancy, the uterus weighs as much as 1,100 to 1,200 grams and has a capacity up to 5 liters. Measurements of the fundus can help to indicate developmental problems. We measure the fundus starting at the suprapubic arch and measure to the top of the maternal patient's stomach and more predominantly up to the xiphoid process. And this dimension in centimeters can help give us a rough estimate of the gestational age in weeks of the fetus. If there is some significant difference, then it could indicate that there are problems with uterine growth, problems with baby positioning, or a possibility of twins. During pregnancy, pressure occurs in the intestine and the rectum. Smooth muscles in the GI tract begin to relax. The stomach doesn't empty as quickly. The kidneys increase in size and volume. The ureters increase in diameter. And hormones can cause changes to the skin, the eye, the ears, and the hair. Circulation increases significantly. In fact, blood volume can increase up to 50% to help meet fetal needs and adequately perfuse maternal organs. It also helps compensate for blood loss during delivery. The number of red blood cells in the body increase, Clotting factors increase while fibrinolytic factors decrease. The size of the heart increases slightly, and cardiac output for the maternal patient increases to about 30 to 50% more than when the maternal patient is not pregnant. The heart rate gradually increases by an average about 15 to 20 beats per minute to the end of the term. And ECG changes are evident, including things like ectopic beats, supraventricular tachycardia or SVT. Left axis and deviation is also a common finding. Sensitivity to body position increases as gestational age increases. Lying supine can create compression on the vena cava, and if this pressure isn't relieved, then cardiac output can be decreased. This is why we encourage maternal patients to be transported on their side to reduce this compression of the vena cava. The diaphragm during pregnancy is pushed up by the uterus, and maternal oxygen demand increases significantly. Progesterone release decreases the threshold to carbon dioxide and causes the bronchi to dilate and helps regulate some additional mucus production. There is a decrease in expiratory reserve volume and functional residual capacity as well as residual volume, but an increase in tidal volume and inspiratory reserve volume. Maternal weight gain averages about 27 pounds. The increased blood volume, intracellular and extracellular fluid accommodates for some of this, as well as the uterine growth, the placental and fetal growth, the increase in breast tissue, and increase in protein and fat deposits during pregnancy. Relaxin softens the collagenous tissues and relaxes the ligamentous system, and the demand for carbohydrates increase significantly, and several hormones help compensate this process. So we can see there are significant changes that occur to mom during pregnancy, and we need to be aware of these changes as they'll impact our assessment and the patient's ability to compensate in various disease processes when we assess and treat our pregnant patients. Some additional considerations: cultural value is an important role. Some cultures have a value system that can affect their pregnancy. Some patients don't permit a male healthcare provider, for example, to examine a pregnant patient, and different cultures view pregnancy differently. To be a culturally aware provider is to be sensitive to the patient's cultural traditions and respect the patient's wishes. We are there to treat and support the patient, not only through emotional support, physical assessment, and physical treatment, but as well as cultural respect as well. So if you find yourself in a situation where you're unsure how to treat or address a patient, communication is often the best way. Ask the patient if they're comfortable, if you assess them, or if there are any additional considerations that may need to be taken into account. Adolescent pregnancy is also of concern. The United States has one of the highest teenage pregnancy rates among developed countries. And remember that pregnancy is possible when assessing all female teenagers. And respect the teenager's privacy and independence, but your assessment should include, and history should include, inquiry about last menstruation cycle, as a sexually active adult female who has begun their menstruation and had their menarche has the capability to become pregnant, and that needs to be at least examined through history and physical. Although understand that discretion may be needed to maintain the patient's comfort, privacy, and respect.